welcome. Thank you so much for joining us today. It is officially kicking off we are officially kicking off the Children and Youth System of Care State Technical Assistant webinar run by the State Technical Assistant team. This topic today is AB 2083 MOU Part 4, Screening, Assessment, and Entry to Care. We have a busy agenda this morning. We are going to introduce all of the partners for the State Technical Assistant team. We are going to share some children and youth system of care updates across those team members. And then we're going to have a special presentation on screening, assessment, and entry to care, including some presentation from San Diego County partners. And then we will have some time for questions and answers as we can. For those of you who are just joining us, welcome. My name is Nancy Hafer. I am with UC Davis and am happy to be proctoring and helping to kick off the webinar. If you have any questions for us regarding the technology or the content of the presentation, please, you can type your questions into the chat window. You can also use the Q&A window. Those are two different features. So the chat will get our attention probably a little bit more quickly, although we all have lots of eyes on the Q&A topic as well. So we have a polling question. I'd like to start before we have introductions from the state team. We'd like to ask you all, let's see, which system partner are you from? And get a little bit of information about you all. We've got behavioral health, child welfare, education, juvenile probation, regional centers, and then the next question is, which area do you represent? And it's so nice to see, as always, lots of answers are coming in that you represent lots of areas and lots of different partners are coming in. Thank you for taking your time. I will end the polling here in just a few seconds. So if you haven't done so, type in your answer. Okay, 2 more seconds. 3, 2, 1. I'm going to end polling and share the results. And you can see, I think this is, we're starting to get more partners from different agencies besides child welfare. I think when we first started doing this, they were pretty heavy on the child welfare. So it's nice to see more partners joining in. And you can see the areas that you represent are program. Lots of program folks are here today, policy, and not a surprise, lots of you wear lots of hats and have overlapping roles and areas that you represent. Okay, thanks for spending a little bit of time introducing yourself. Let's start off introducing the state team with the Department of Developmental Services. Christine, do you want to kick us off?
Sure. Hi, my name is Christine Bagley. I'm from the Department of Developmental Services. I work in our safety net unit, which also includes our system of care efforts with regional centers. Thanks for having me.
Excellent. And then let's move to the Department of Education. Renzo?
Good morning. This is Renzo Bernalis. I work in the Foster Youth Services Coordinating Program in CDE, or at CDE. Thank you for having me here this morning.
Thanks, Renzo. Department of Healthcare Services.
Good morning. This is Lindsay Merwin with Department of Healthcare Services. I work in the Medical Behavioral Health Division. Thank you for having me today. I'm going to pass it to Olivia.
Great. Thanks, Lindsay. Olivia is reaching for her unmute button.
Uh-oh.
There you are.
Good morning,
Okay.
everyone. My name is Olivia Almaraz. I am a health program specialist at the Department of Healthcare Services, Program Policy Unit, and also part of the System of Care efforts.
Excellent. Thanks, Olivia. Is there anybody else from Department of Healthcare Services this morning?
We can go ahead and move on to Department of Rehab.
Okay, great. Excellent. Department of Rehabilitation. Can be a long walk to the unmute button. Nancy, are you here with us? Okay, we're going to wait for her to introduce herself and we'll move to the Department of Social Services.
Good morning. I'm Ashley Franklin. I work on System of Care with the Resource Development and Training Support Bureau at Social Services.
Hello, my name is Diana Wagner, and I work for CDS within the Continuum of Care Reform and get the opportunity to work with this great team as part of the System of Care.
And good morning, I'm Rich Connect, an Integrated Services Advisor at the Department of Social Services.
Excellent. Thanks, Diana, and thanks, Richard. And I'm not sure if it was just me, but both of you were a little bit quiet. So maybe next time, turn up the volume just a little bit. And is there anybody else from the Department of Social Services here with us today? Got it. Okay. All right.
That's it.
Okay, so moving on to updates. So thank you all for joining us today. And if you've joined us today, you were able to register in our new Zoom link. So we apologize for the confusion with that. We had some learning curve with different kinds of Zoom links and recurring meetings. So what you may have noticed is that before, when you registered, we registered for the whole entire series, and they may have downloaded onto your calendar, or they may have downloaded onto another calendar link, and it was confusing. And so what we did is decided to stop using the recurring Zoom links and just create a new Zoom link for every single webinar that we have. So we will send a unique registration for February. I think it's already gone out, and the same for March. So every month you will register for a new webinar. If you have any questions, you can email the System of Care team. You can email us at UC Davis, and we will make sure that you get in the webinar on the right day at the right time. But it is a little bit different than it was before. So thank you for your patience. We really appreciate your tenacity and taking on the technology in the year 2020 and 2021. So Ashley, would you like to talk about the TA opportunities?
Yeah, and then related to what Nancy just shared, you're always welcome to email us to be added to the distribution list so that we can keep you updated. So you can email systemofcare@dss.ca.gov, and we can get you added to the distribution list so you can get updates about the links as our monthly webinar announcements are sent out. And then we'll also share a quick reminder that any counties that are interested are able to have their draft AB 2083 or Children and Youth System of Care MOUs reviewed by the System of Care state TA team. The team's able to provide a cross-system review and feedback to your local team with comments, and then a follow-up call for any further discussion you might be interested in. And to request a review of your draft MOU, you can email that same email address, systemofcare, all spelled out, at dss.ca.gov, and we'll make sure you have an opportunity to grab that email address a few times throughout the presentation today.
And it looks like Nancy Wentling was able to call in. So Nancy, would you like to introduce yourself as the Department of Rehabilitation? Although I think I just did that for you.
Hi, everyone. It's Nancy Wentling from Department of Rehabilitation. I'm really happy to be here today. Thank you.
Awesome. Thank you, Nancy. Glad to see you today. Okay, so moving on for some more System of Care updates to Renzo with the Department of Education.
So the Department of Education has released a new absenteeism by reason report. That report is now available on DataQuest. DataQuest is the web page where you can look up multiple different areas of information on California school districts. This particular report includes the average number of days students miss school and the reasons for why they're missing schools. The report is available under the subject School Climate on the DataQuest webpage and can be viewed under the level of school, district, county, and state for foster youth and other student groups. The link provided on this slide takes you to the DataQuest website, and you can use the filters there to access the new report. Also, the CDE has released the 2019-20 high school graduation and dropout report. That report shows the graduation rates for foster youth improved a little bit over previous years, and that report can be accessed through the hyperlink that's provided on this slide. As of the first week of January, the Department of Education, the Foster Youth Services Coordinating Program, has released and posted a guidance document on best interest determination and how it's connected to school stability and school of origin rights for foster youth. That guidance document was in response to a survey that was sent out to foster youth coordinators sometime in 2020. I can't remember when we sent that survey out, asking for what areas of guidance and technical assistance our coordinators were looking for from the Department of Education, and best interest determination came up as the main area for guidance to be provided. The Department of Education drafted that document, got in contact with the Department of Social Services, and we're happy to announce that that letter went out as a joint guidance document, which means that the Department of Social Services spent quite a bit of staff time reviewing, providing feedback, and ultimately also approving the release of that particular guidance document. So currently it's made available on the California Department of Education program page for foster youth services programs under the resources tab. And it is my understanding that Department of Social Services is working on a letter to introduce that guidance document, and they will be sending that out to county child welfare coordinators. At this point, CDE has sent that to county foster youth services coordinating program coordinators, as well as superintendents of county offices of education. That's it for my update. Thank you.
Thanks, Renzo. Okay, moving on to the Department of Social Services updates.
Sure. And then I think we're going to squeeze Christine in somewhere to do a brief, share out a little bit about an early start resource. So Christine, you can go now or maybe at the end.
Yeah, I'll hop in after you.
Sounds good. So I am going to share out a few of the national technical assistance opportunities that have come up recently. I'll share briefly about them, and then I'll also add information into the chat with links in case you're interested in exploring any of those further. The first is the Institute for Innovation and Implementation is offering a free national technical assistance opportunity. They're launching this monthly training institute series with a choice of 2 virtual 90-minute workshops focused on integrating systems and improving outcomes for children and youth and young adults and their families. That training institute kickoff happens tomorrow, actually, January 14th, and then the series will run the first Thursdays from February through September, 10:30 to 2. 10:30 to 2. The next is a technical assistance opportunity related to addressing Family First Prevention Services Act requirements, a 2-part recorded webinar series from the Child and Family Evidence-Based Practice Consortium that supports organizations and systems in the selection, installation, and implementation of evidence-supported programs. The first webinar examined the key factors of program selection and implementation as presenters review a support tool developed by the consortium to assist with focusing through these criteria. The second session examined how to apply the tool in more depth and provides examples of its use. I'll throw that link in the chat in a moment. The next is another recorded opportunity, considerations for systemic care leaders in implementing a continuum of crisis services. The session of the Systemic Care Leadership Learning Community focused on the implementation of a comprehensive continuum of crisis services for children, youth, and young adults in systemic care, with a particular focus on the mobile response and stabilization services. Presenters defined a goal of the crisis continuum, the components, financing strategies, workforce strategies, and the outcomes achieved by the state and communities. The value and elements of mobile response and stabilization services were described, and an example of a statewide system was provided. That recording is part of the System of Care learning community on ideas at the Institute, and I'll be sure to share that link too. And lastly, we'll share the Traumatic Stress Institute has announced a new learning collaborative related to trauma-informed care in organizations that serve those with intellectual and developmental disabilities. The Traumatic Stress Institute, or TSI, is a leader in supporting the organizational transformation to trauma-informed care and is offering a 12 to 16-month pilot learning collaborative for organizations that serve intellectually disabled and developmentally disabled folks interested in implementing this trauma-informed care. The Learning Collaborative will begin in spring 2021, and you can check out more about that opportunity on their website also. So Daniel Wilson, next from CDSS, is going to share a few updates. Daniel, are you able to chat with us?
Yeah, good morning, everyone. My name is Daniel Wilson, CDSS with the Early Practice Interventions for Children and Families Unit. Just have a few updates about opportunities regarding wraparound and peer partners. And I'll also put the information in the chat feature. So our next wraparound advisory committee meeting is this month, January 28th. And the California Wraparound Advisory Committee meeting, or CWAC, is a group of folks who come together, providers, counties, parent partners, youth partners, to make recommendations, identify and share solutions, promote best practices related to wraparound policy and program improvement. And at this wraparound steering committee, this wraparound advisory committee meeting specifically, we'll be discussing wraparound and how it relates to the aftercare requirements of the Family First Prevention Services Act. And aftercare requirements meaning transition from congregate care STRTP facilities. Additionally, associated with the California Wraparound Advisory Committee meeting, we also have regional hubs that meet quarterly. And these hubs are opportunities, really it's a grassroots effort, the hubs, where folks kind of come together at a grassroots level regionally to do some peer-to-peer sharing, collaborative practices, support one another, discuss relevant topics. Both UC Davis and CDSS has a presence at each of the hubs. However, they are led by wraparound providers and counties who have wraparound programs. Again, it's very grassroots and organized at the regional level. We attend to support and kind of provide that state perspective. The next Northern Wraparound Hub is February 4th. The next Central Wraparound Hub is January 15th. And the next Southern Wraparound Hub is February 22nd. And then last but certainly not least, CDSS in collaboration with the Parent Partner Advisory Committee and the UC Davis Resource Center for Family Focused Practice introduced regional peer partner hubs, which are based very much on the wraparound hubs. And these peer partner hubs are really opportunities for peer partners, meaning folks with lived experience in one of our child serving systems, to really come together and provide mutual support to one another, peer-to-peer learning opportunities. At this, the next peer partner hub on January 14th, the focus will be on father engagement and a presentation by one of our Parent Partner Advisory Committee members and father and peer partner, parent partner in Riverside County. So that should be really great. And we really try to maintain the integrity of the breakout groups into the regional peer partner hubs to really limit those to folks who have lived experience, to support it being a safe space for folks to really come together and support one another and do some mutual learning and peer-to-peer sharing, and even advocacy to those of us at the state and county levels of what they need to feel supported across the state. So those are coming up, and then the registration information for each of those is in the chat feature. They're all free. They're all open to anyone who would like to attend. We ask everyone, whether you attend or not, feel free to pass on to your respective networks, and especially the peer partner hub, so we can really support our peer partner, parent and youth partners, folks with lived experience around the state as they support the families that we're all trying to work with. And if anyone has any questions, each of those links have our email address listed on the website. So you can email us if you have additional questions, or you can reach out to me in the chat feature. And that's all I have. Thanks, everyone.
So I'll jump in again. This is Christine Bagley from the Department of Developmental Services, and I just wanted to share with you all that do a plug for Early Start. We know that early intervention for our infants and toddlers is really critical in their early development and social, emotional, and bonding. And so through COVID, we've seen some impacts to Early Start referrals. And so I just want to take this moment to kind of let everybody know that regional centers are still taking referrals for Early Start. And there's 3 documents that I'll share in the chat. One is an Early Start healthcare provider brochure. One is an Early Start community flyer. And then there's some social media and newsletter kind of scripts that you can utilize. So these are great tools to use and share with your professional partners, your, any sort of social workers, service coordinators, so that they can ensure that we're getting the referrals to the regional centers for Early Start. So I have them in a variety of languages. And so I will put in the chat either the links to access them or the documents themselves. So thanks.
Thanks, Christine. Okay, while we check in with the team to see if there are any last updates, I'm going to launch our next polling question, which is, which of the past webinar topics have been most helpful for you? For those of you who have attended, select your top 2, and this is multiple select, so you can select more than one. So this is really just an opportunity for our team to learn more about which ones, which learning opportunities have been the most successful for you, might indicate which topics you're most interested in diving deeper on. It gives us an opportunity to take a minute to consider which have been the best webinars. Christine, do you have a favorite webinar?
I don't know. It's hard to pick. Honestly, I kind of liked the open forum that we had. I think people really liked being able to engage with one another, and I think the exchange and the sharing of ideas and experiences is really really valuable. So I think that was probably one of my favorites.
Awesome. Excellent. Thanks, Christine. Okay, I am going to share with everyone, see if they had similar. Let's see, we've got, I think everybody can see this right now. Lots of folks appreciated the integrated core practice model, the September webinar. Great, thank you for doing this. This is good information for us to have to see which ones were the most helpful and help us guide future. I've got one more polling question, and then we're going to start with our presentation unless there's any other updates. And this one is, are your local system of care screening and/or assessment processes used by each of the partner agencies, etc.? Yes, no, need TA, or in progress with no needed technical assistance? And this seems like a really great one. If you haven't answered a polling question yet, this seems like one that could be really, really helpful to dive into answering your first polling question, as it will help us understand where more additional TA is potentially needed. And I can see, because I'm a host, I can see the answers that are jumping around, and we are getting a lot of responses to this. We've got a lot that are in progress that don't need TA, and a fair amount that would appreciate some more technical assistance. And I'm assuming that the state technical assistance team is asking this. Is it something that they're considering? So I'm going to end polling and share those results. And you'll see it was a pretty even tie. Yes, no, needs some TA, and with just one fewer response, it's in progress, no needed TA. So that's some really great information. Thank you for your time. All right, are there any other system of care updates? Waiting for a shake of a head, no. Okay, so let's move on to our presentation. Lindsay Merwin.
Thank you, Nancy.
Yep.
All right, so if system of care is new to you, these next two slides are a brief overview. The legislation calls for some deliverables, one being the Memorandum of Understanding, also known as the MOU. A lot of you are probably working on it or have already finished it. The team has developed MOU guidance to assist counties. This guidance is currently posted on the California Health and Human Services website. The state interagency team has released All County Letter 2063, which describes how counties and local partners can request technical assistance. We are currently working on the gap analysis and the multi-year plan. Next slide, please, Nancy. Thank you. So Assembly Bill 2083 was authored by Assemblymember Cooley and was chaptered in 2018. The intent of the legislature in adopting the bill was to build upon the current continuum of care reform implementation effort by developing a coordinated, timely, and trauma-informed system of care approach for children and youth in foster care who have experienced severe trauma. The bill requires each county develops an MOU, as mentioned on the previous slide, setting forth the roles and responsibilities of agencies and other entities that serve children and youth in foster care who have experienced severe trauma. We have worked with our state, county, and local partners to better serve children and youth who are receiving services from multiple public programs. Our goal is really simple. Our programs must meet the needs of the children that we serve. These are our collective children, and they all deserve the very best. Next slide, please. So some recent learning that we've had, your MOU development will thrive when all local AB 2083 system partners and agencies are actively and authentically participating in the process. If one or two partners draft the MOU and then take a finished product to the other partners, it's not likely to be collectively impactful. This process should naturally foster your county's system of care implementation, getting each system partner comfortable working together across systems rather than in silos. Too often, we're focused on delivering specific programs or services within our government silos that we don't take the time to look at how our programs and services complement one another to best address the needs of the children and youth we serve. Siloed systems typically yield siloed responses. Although collaborative MOU drafting may happen outside of the interagency leadership team, MOU approval should include your ILT. All members of the ILT should have the opportunity to review and approve that MOU. And then next slide. So we're going to be going over the MOU Part 4, Screening, Assessment, and Entry to Care. And I am going to be passing this to Richard, I believe, unless Diana is stepping in for Richard to go over it.
Thanks, Lindsay. Really appreciate that. We're going to spend a few minutes today talking about the first of the MOU elements that has to do with the practice level components of a system of care. We can go ahead to the next slide, Nancy, thanks. So the first three MOU elements are really part of the systemic architecture or the structures that local systems put in place for system of care. Part 4 represents the first, again, of the practice level. So it's really critical, super important. And so we have a couple thoughts here for you. While the Assembly Bill 2083 legislation in California, which invites us to system of care, is very much focused on foster youth, the essence of a system of care is that entry to care and access to care should be maximized for all youth to the extent that local systems can do that. In other words, a focus solely on foster youth by a system of care is likely to yield less than a full impact. The more we can create access and entry points to services before young people need the deeper end services through welfare, probation, intensive mental health, regional centers, or intensive mental health through schools, the more we can create access and entry upstream, the less traumatizing, less costly, less stigmatizing care will be required. I'm reminded of one of my favorite sayings that it goes something along the lines of, until every child is someone's child, there will be some child that is nobody's child. And this applies to public services in a very real way, and really is a guiding framework for system of care. Next slide. So one of the points to remember contextually to why alignment and connectivity around assessment and entry is critical is that we often find ourselves traumatizing young people and their caregivers inadvertently by making redundant or duplicative screening assessment processes. And this is typically characteristic when care is provided from multiple agencies, right? So the very essence of system of care invites us to share assessment and the minimum necessary background and history information allowed by law between system partners in order to align services. And then once that teaming process begins, during the engagement and assessment phases, that's the place really where partners' assessments should be brought forward and used toward striving towards a singular, uniform, or aligned service plan. So assessment, again, first critical step in that entry process towards a unified service plan. Next slide, Nancy. Wanted to spend a couple of moments just reflecting on the integrated core practice model and how it provides a framework for entry and assessment to care. Most of you are familiar at this point with the phases of care within the state's ICPM. And you'll see those reflected here 1 through 5. There is some local modification, of course. Sometimes we throw ideas around team formation in with the engagement. Sometimes engagement and assessment are found together. Regardless of how local systems conceptualize or practice the ICPM phases of care, what's critical is a recognition that within the ICPM there is guidance that can help and support not only the construction of your MOU, but the effective alignment, the synchrony of a screening, assessment, eligibility determination, all those processes that are very rules-based and prescriptive. In a system of care, we can sometimes help young people and families navigate them in ways that expand access, and ICPM provides guidance around that. Next slide is just a really quick reference to one piece of that guidance. And we just offer it here for your reflection on page 5 of the state's integrated core practice model. You'll note that, that it's in those first contacts where engagement, of course, is established and where empowerment is taking place, listening authentically, inviting reflective expertise from the youth and their caregivers and their natural supports. This is the essence of alignment around assessment and care planning. I would just add, as I pass it on to Christine here in a moment, that we are updating contextually, again, the ICPM in the next few months, finishing up a stakeholder engagement process with a number of critical new partners to system of care. And we hope that by sometime late summer, early fall 2021, that the next iteration of the ICPM will be available to all system of care partners and their collaborators locally. Christine?
Thanks, Richard. So these next two slides are pulled from the MOU guidance, which is posted on CHHS's System of Care website. So if you haven't had an opportunity, that guidance will really kind of help you tease out various sections required for your MOU. And so I think, you know, Richard kind of spoke to both of these next slides, but these are just some considerations as you're discussing and kind of planning and crafting this section of your MOU. And just kind of some thoughts around, you know, how can you have, you know, your separate processes, but really be intentional about not having families, children, and youth kind of have to replicate experiences or duplicate processes. Next slide. This next slide is the same thing. You know, how can you share information amongst each other to kind of reduce those assessments and really also the outcomes of the assessments and sharing that via your combined teaming process. So again, just really trying to craft this section of your MOU to reduce duplication when trying to access our various systems. And with that, I'll turn it over to Renzo.
So this section of the webinar provides you with some questions to reflect on the contents of your MOU as it pertains to assessment and entry to care. So looking at opportunities for the development of processes that assure that youth and family members are consistently being referred to other system partners, such as a mental health plan or a managed care plan, so that those systems can engage in their own screening and assessment processes to determine if there is eligibility, and then to have common planning about how we're integrating the different services that are being provided by different by the different system partners. Also looking at how the child and adolescent needs and strengths assessment that's being used by child welfare and probation and behavioral health, how that process and those requirements can help enhance communication between all the system partners, and how that process can help inform a common planning process to develop the care plan for each youth, so that those care plans are holistic and have meaning for each of the system partners. Next slide, please. Additional questions about process. What's the process that's identified in the MOU for identifying and addressing urgent service needs, which could include residential services, hospitalization, placement instability, and others. Does your MOU reflect a process for case plans where those case plans are reflecting the assessment information that's been generated by all system partners? How are we utilizing that assessment information in common case planning for our youth and their families? And do you have a county identified process for referring students and families to other county agencies and community-based providers? Such as an example, how does your process for referring connect to multi-tiered system of support framework as utilized by public education? Next slide, please. Again, does your MOU contain processes and commitments to reduce redundancy? How are you utilizing your county MOU structures to pull together information and share information in a way where families are not having to report on that same information over and over again as they engage with the individual system partners. So how are you creating a process and a system to have your youth and families provide information that is at that point then shared with the rest of the system partners to reduce the amount of interaction that your families and children have with answering the same questions over and over again. Same question for regards to screening and assessment processes. How are we aligning those in a way that it supports timely referrals between agencies and it reduces the amount of stress that's being that our families and children are being subjected to as they're having to go through this assessment process? And are the processes that we're using, including those referral structures that are being incorporated into the MOU, are those structures and tools that are being used culturally responsive for our children and their families? Next slide, please. So the MOUs themselves need to be reflective of each system's assessment and intake processes so that it allows for each of the systems to be able to adhere to their timelines and completeness standards, but again, in a way that we're helping to link those processes so it's seen as one process by our kids and their families rather than 3 different processes or 4 or whatever the case may be. Within your MOU, consider the development of a single coordinated intake and assessment process across all systems, including the use of a common or universal services form where you can see all of the services being provided through all of the different system partners. For some youth, utilizing a timely CAN screening assessment and utilizing that assessment as a means of trying to reduce duplicative screenings and using that CAN's engagement to align with the approach established by Pathways to Wellbeing. And I think I may have gone into somebody else's slide at this point, but I'm not sure. But I think we're ready to go to the next slide.
So Nancy, really quick, and Renzo, if I can just say something about that point number 3 there on that slide. So if we really think about it, and Richard mentioned earlier in this presentation, like continuing to reassess children has the potential to re-traumatize them. And so if county child welfare and mental health are already providing timely CANS assessment at intake or entry to care, then there is not a need to do an additional screening for, we hear from counties, a KDA screening in addition to that CANS process. So just keep that in mind as you're developing your MOU, because we do want to decrease the amount of trauma that we potentially expose children and families to.
Nancy, can you remind me real quick if I'm covering this one or if I've inadvertently gone into somebody else's slide? Sorry.
I'll cover this, Renzo.
Okay.
Awesome. Thanks,
Thank
Diana.
you.
Thank you, Diana. Sorry about that.
That's okay. We're flexible. We can go with it. So some additional points that should be covered in your local MOUs are making sure all relevant system partners are participating in the team meetings and process of the care entry and coordination. Looking at describing the process by which assessments will be shared across the systems in a time frame involved in order to reduce duplicative assessments. This is particularly important that honestly we're experiencing for the youth returning from out of state, in making sure that the information is shared across systems so that we can address the needs of the youth. So this is something we really need to focus some energy on, not only within AB 2083, but across our entire state. And additionally, we want to establish a process for expedited service approvals in order to reduce placement instability and hospitalization. Whenever a child is placed in a residential program, ensure there is a process to identify and develop the services and supports needed to effectively transition the child to their permanency. And the next slide is going to be Lindsay that will be presenting.
Thank you, Diana. So if EPSDT is new to you, I will go over what that is. And then as you can see here, you have the child in the middle of this picture and the EPSDT programs that are available around them. So some people think that early and periodic screening, diagnostic, and treatment benefit is as an entitlement for Medi-Cal services in California. Other people consider it to be a protection for children to receive necessary covered services that are specific to their needs. I like to describe it as a preventative and medically necessary Medicaid coverable service for individuals under age 21 who have full scope Medi-Cal. And all of these ways to think of EPSDT are accurate. And what these all have in common is the broad nature of the EPSDT coverage. So you have school-based Medi-Cal, Medi-Cal dental, children's Medi-Cal services, sorry, not Medicaid. Let me scroll down here. And then MCPs and FFS, and then mental health services. And underneath all of these services, it also describes under mental health services what exactly is available to the child. And next slide. I believe that's you, Renzo.
This is, so I'm not going to go into detail into each one of the circles or bubbles that are here. So the intent of this slide is to show how students and families should be viewed being in the middle of the public education system. And these are some really broad general areas of services that our local educational agencies, which include school districts and county offices of education and charter schools, provide to kids, ranging from what you would traditionally think of as academic programming all the way through providing for food instability or insecurity needs. And the intent of these slides is to really show the complexity within each one of our individual systems and to do a little bit of a shift in our thinking, because traditionally we see this as living in public education only. But if we're really looking at how we are serving children and families at the center, then we start to have this much broader, more holistic recognition that each one of these pieces that previously we were thinking about as only being part of public education actually make up a component of a county's larger children and youth system of care. So when we get through looking at each of our individual departments and what they provide through their programming and through their systems, you get a much broader, may I say even more complicated picture of what a children and youth system of care looks like, but it opens up a lot of opportunity for piecing together pathways of connecting each of the things that are being provided as visually represented through the circles together to really provide holistic care planning and integrated service delivery for our children and their families. Next slide, please. This is Christine.
For the Department of Developmental Services, the regional centers administer two programs, Lanterman Services and Early Start. Early Start is our program that offers supports and services to infants and toddlers and their families, ages 0 to 3. And then Lanterman Services has a different eligibility kind of criteria, which can include 0 to 3, but typically begins from 3 across the lifespan. And underneath each of these programs, Lanterman and Early Start, there's a variety of services and supports that can be offered. And so to meet the needs of the individual. The department also operates some state-operated programs, which consist of some acute crisis placements, crisis stabilization response kind of unit, and then also our developmental center, Porterville, which is for adults. So again, you can see that there's a variety of programs which house a variety of kind of services or a continuum of services that are available to individuals that meet the eligibility requirements. Next slide. Diana or Ashley, I think.
Yeah. So within child welfare, really we've got this little bubble that I want to focus on just a little bit that says prevention. And we know that by the end of this year, or this year that we're in now, Families First Prevention Services Act will be rolled out. And so we're really hoping to grow that bubble so that we decrease the size of those kids entering foster care and also continuing in out of home care. So that will be a focus over this next year and into the future of just really wanting to provide the services to families prior to their children being removed. As part of child welfare, we do have the entry assessment and eligibility, which is looking at that front end of referrals and investigations that occur. We have placement pieces that consist of resource families, intensive services foster care, therapeutic foster care, short-term residential therapeutic programs. We have ongoing supervision provided by social workers. That includes monthly assessments by social workers, the court process, visitation. There's definitely intensive case management and services throughout the process of a youth and family within child welfare that includes screening assessments and linkages to services, and also teaming, as we all well know, with the child and family team process. And also looking at aftercare with adoption services and extended foster care and guardianship. The next slide. So within probation, traditionally folks think about the 600 and 602 access and entry to care. But I think there's some real exciting part of probation work that's being done that focuses on really maximizing the informal probation by using the juvenile justice crime prevention work in tandem with the youth offender block branch to really do some prevention work. And I really want to celebrate probation in that if we look at the last 15 years, California really has led the country in trauma-informed care and services that are provided to their probation youth. And they have decreased the number of youth entering formal probation by over 50%. So just really want to celebrate the work that probation has been doing here in California. And now I will turn it over to Nancy with Department of Rehab.
Thanks, Diana. So everyone can hear me okay? Want to check technical challenges this morning. So I'm very excited to share a bit about the Department of Rehabilitation services that are bubbleized on this slide. But first really want to note that Department of Rehabilitation is committed to providing DOR, what we call DOR student services, vocational rehabilitation services, and supported employment services to youth and students with disabilities who are involved in foster care, with the goal to help them thrive in the world of work as a pathway to independence and equality. And the disability could be physical, emotional, psychological, learning, cognitive, combination of the above. But so this slide highlights 3 buckets of services that we provide to youth, students and youth with disabilities. The top left bucket is titled DOR Student Services, and these include job exploration, counseling, work-based learning experiences, assistance with post-secondary education counseling, workplace readiness, getting them ready for the world of work, and then instruction and self-advocacy. And it's for students with disabilities ages 16 to 21. And it includes partnerships with CDE as well as local educational agencies. And these services are really designed to support students and youth with disabilities who have not yet embarked on work, or they've had a rocky start because of their different situation in life. And the services really set the stage for them to be more successful in employment. Department of Rehabilitation, our mission is kind of 3-pronged. We focus on employment, independence, and equality. And we know, most of us here, that employment really is a route to improving the opportunities for independence and equality. So bucket on the top right is titled Vocational Rehabilitation Services. These services include career assessment and counseling, helping with job search and interview skills, independent living skills, career education and training, and of course assistive technology to help the student or youth maximize their ability to live and work independently to achieve that economic sufficiency at time, right? So these services are available to students and youth and adults, and it covers a continuum of employment needs across someone's life. And then the lower bucket is titled Supported Employment Services, and these include employment and supportive services for youth with the most significant disabilities who might require long-term support to learn and perform job duties needed to be able to retain employment that's going to assist them. And we partnership with DDS with supported employment. So just to kind of recap, in the last few slides, we've seen a wide variety and a spectrum of services available to children, youth, and families who are involved in the foster care community. So I'm gonna ask Nancy to move the slide forward so we can take a look at how these programs create a universe of services available to those that we serve. So if you look at this puts everything together. It's pretty amazing if you look at it, but in looking at all of the pathways into care and support, we see that there truly, really is a universe that's supporting children, youth, and families. And separately, like Renzo mentioned too, we know that our programs and services make an impact and they make a difference, but this slide is really highlighting and representing the different ways and the different paths to raise the bar on support so that we can all, while working together, make an exponential difference in the lives of the folks that we serve. So this is our universe of services, covers all the needs, right? It provides a variety of solutions and each support the work of each other. So I'm inviting everyone to truly imagine the possibilities and immense impact on the children and youth across the state as we learn and understand the different roles and offerings that our system of care really offers to those in this community. So with that, I'm going to pass the mic, I believe, to Richard.
So hi, this is Diana. Richard had to hop off, but I'm going to get through the next few slides rather quickly to make sure we have enough time for our San Diego partners. But in regards to screening, assessment, and entry to care, shared funding opportunities, I think it's really important as you read this slide here to think about if we really want to maximize alignment and access to care, we also must look at the funding and align this with the fiscal resource and management sharing. So that's part 9 of our MOU. So these two pieces, 4 and 9, must work together in order for us to really do the work that we want to do. you move to the next slide, Nancy? And I think that there are many new opportunities to enhance partnerships that are up and coming or have already or recently been released. And these are areas where access to care and expansion of service efforts are happening now. And therefore, additional access to services in theory could have fewer youth entering the foster care system or being placed in out-of-home care. And so really our efforts around CalAIM and with Senate Bill 75, which is Medi-Cal for students, Family First Prevention Services Act, and then also the SB 823. We're really looking at these as opportunities to get services to children by leveraging system partners and working together. And therefore, we would decrease the number of youth that enter the foster care system. Next slide. So we really want, with the screening and entry to care, we want that focus to be on prevention. And I talked earlier about really wanting to expand that prevention bubble that was in the earlier slide. We want to effectively coordinate and deliver significant reduction of demands on system of care programming and cost. And this can happen by us working together. Many children and youth can best be served within their community setting, preventing the need for public system services. And even youth with complex needs was once a youth with basic needs. And so by focusing on those prevention pieces, we're able to stop them from being those high-end kids that we are seeing right now with our out-of-state youth. Next slide. So some of the recommendations we have in order to really do this work is to ensure that fiscal managers understand and share their budget planning process in support of expanding access. And so really this is an opportunity for fiscal and program folks to truly work together to meet the needs of the youth across the system partnerships. Also use of Child Abuse Prevention Council, prevention cabinets, the MTSS, or other community-based engagements as pathways to care, rather than kids ending up in the foster care system. So right now, I would like to go ahead and welcome our San Diego team that is here with us today to present and share the work that they are doing in San Diego.
Good morning. Thank you, System of Care Technical Assistance Team, for inviting us to share our system of care work and teaming efforts in pursuit of the No Wrong Door policy in San Diego. And to our state and county partners that are on the call this morning and coming together to collectively accelerate the system of care work, good morning. We hope that through this sharing, you are able to grow from our lessons learned and really take away ideas for practices for success, and to continue enhancing what you already are doing and doing best. My name is Jenny Rodriguez, and I am a policy analyst with the County of San Diego Child Welfare Services. And it's with absolute great pleasure that I turn it over to our county AB 2083 System of Care team for introductions. So if I can just toss it, maybe Mindy, you're the first one I see, and then we can take it from there.
Good morning, everyone. My name is Mindy Cookage, and I am from the Foster Youth Services Coordinating Program within San Diego County, and I will pass it to Shelley Paul.
Good morning, everybody. Shelley Paul, mental health policy analyst with Child Welfare Services in San Diego.
Mike.
Hi. Go ahead. Hi, good morning. I'm Mike Green. I am a program manager with San Diego County Child Welfare Services. And Seth?
Hi, everyone. I'm Seth Williams, and I'm a behavioral health program manager with Behavioral Health Services in San Diego County. Mandy? why don't we go to,
Mute.
oh,
Good
sorry.
morning, everyone. I'm the program manager for Pathways to Wellbeing in San Diego Behavioral Health Services. And I will toss it to Carol.
Good morning, everyone. My name is Carol Vaughn. I am a program manager with San Diego Regional Center. And Kate, are you on?
I'm here. Good morning, everyone. Kate Pinamont. I'm the Director of Case Management Services here at the San Diego Regional Center. And I think I will pass it to, okay, I have to look at my screen here and see. Karen?
Good morning. My name is Karen Kolb. I'm from the Rincon Band of Luiseño Indians, and I'm the Director of Social Services, Tribal Family Services here at Indian Health Council.
Jamie?
I am Jamie Tate Simons. I am the SELPA representative in our group. I am the SELPA director for North Inland SELPA, which is in the northeastern region of the county, but we do have 6 SELPAs within San Diego.
And Pablo.
Good morning. This is Pablo Carrillo. I'm with San Diego County Probation.
Wonderful. Thank you, team. And I really hope I didn't miss anybody. As you can tell by our introductions, we not only do a lot of collaborative work here, but we also do a lot of collaborative presentations. So in partnership with the team, we are excited to share what screening, assessment, and entry to care look like for youth here in San Diego. I'm just going to ask if we can advance. Next slide, please. There you are. Thank you. So this presentation is not only focused on what we're going to talk about with screening and entry to care, but it's really aligned with and supports the Live Well San Diego vision. And the Live Well San Diego vision is our county's vision for a region that's building better health, living safely, and thriving. And it aligns with efforts of individuals, organizations, and government to help all 3.3 million San Diego residents live well. What's important about Live Well that we feel is fundamental in sharing is that it involves everyone. It involves healthcare providers, community and faith-based organizations, businesses, school districts, and other jurisdictions, including cities, tribal governments, and military or veteran organizations. And only through that collective effort in which all of us work together toward a shared purpose can meaningful change be achieved in a region as large and diverse as San Diego County. The County of San Diego and its affiliated partners are committed to support the Live Well San Diego vision and embrace an understanding that children and youth in our communities are our collective children and thrive with committed, permanent, and nurturing families, and when provided with necessary services and supports that are integrated, timely, comprehensive, and culturally responsive. And in combination, the County of Live Well San Diego and the county's system of care vision provides for highly collaborative interactions and uniquely positions us to achieve success in our system of care mission, which is to provide that highly coordinated, integrated, and innovative services and supports to our collective children and youth in order to achieve permanency, well-being, and a valued and successful adulthood. Next slide. San Diego County's system of care work is not viewed as a silo effort and cannot be possible without these strong collaborations and robust conversations and discussions among team members of committed and dedicated partners all coming together to do the right thing for children and families. Our Live Well San Diego vision has laid that foundation for a participatory process to engage populations and systems and provide pathways for improved outcomes for all residents. Our partnerships in our system of care work involve both traditional, non-traditional, established, and new partnerships. Our system of care partnerships extends from the county child welfare, behavioral health, juvenile justice systems, to our partners with the County Office of Education, SELPAs, and Regional Center, and further on to the partnerships and voice of our juvenile court system, court-appointed special advocates, and our tribal nations. Together, we all share in that responsibility of our collective children and youth. With San Diego being the largest region and the highest number of tribal nations, 18 in total, we actively pursue and integrate partnerships with numerous consortiums to ensure tribal voice and representation is integrated into our practice, policy, and vision. We are not an exclusive group of system of care partners. We also recently welcomed San Diego Department of Rehabilitation as one of our newest partners to join the San Diego system of care effort. And we continue to forge new relationships as we move forward in our commitment to our work and the children and youth and their families. Next slide, please. As you can see, with the diversity of system partners, services, and the varying scope of work that each partner or each system partners are aware of, we are aware of the different types and purposes of screening and assessment tools, and how some are similar and overlapping. Here you see an array of assessments specific to each partner, likely with varying timeline requirements and alignment to statutes, both state and federal, such as the Lanterman Development Disability Services Act and the Individuals with Disabilities Education Act. Our county system partners recognize the need and importance for a unified assessment process upon a child or youth's entry into care to reduce that unnecessary duplication of screening and assessments, and to facilitate a complete and comprehensive assessment of needs, services, treatment planning, or case planning. Along with the recognition and awareness comes questions, a lot of foundational next step questions, such as how do we navigate this? How do we even begin these discussions? How do we start to move in a direction of shared assessments? As a start, our county identified areas and opportunities to share assessment outcomes to the extent permitted by laws and regulation to advance our effort in avoiding that redundancy and unnecessary assessments. We have also identified action steps and opportunities for improvement, which we will share in the next few slides, that will help keep us in the right trajectory, such as improving our work with common assessments and coordinating the use of common assessments when available, as well as identifying steps towards the use and practice of universal screenings. Next slide, please. It's really important that at this point, and before we really start jumping into the meat and potatoes of this, I would like to spend a moment here to really just take a step back and provide some context and background to illustrate how we were able to respond and act on the questions asked in the previous slide, which was, how do we navigate this? How do we begin these discussions? And how do we shift the trajectory of our practice to start to move in a direction of shared assessments upon entry to care and at other major decision points in a child's journey in the system of care? It was quite evident at that point that this would mean reflecting on our relationships with all partners and scaffolding on earliest successes and teaming adventures. And that we did. We borrowed on the early partnership and collaboration successes of our implementation of the integrated core practice model and the pathways to well-being rollout in our county. We reflected on what we were doing well, and that was teaming. When we began our work implementing the core practice model, CCR, and other large system initiatives, our county made a commitment to ensure that all impacted system partners were at the table early, involved in regular leadership and implementation meetings. This process ensured all partners were informed and involved. It also improved relationships between system partners and led to cross-system education, meaning our systems understood each other better. So these early efforts to collaborate on system reforms have made our AB 2083 endeavors much easier to achieve. Even now, when we have system-wide issues to address, or even when we have a child, youth, family-specific need, we ensure all partners are invited, engaged, and involved in planning. The success of our CFT meetings are an outcome of our early teaming efforts. And this cleared a pathway for our CAN's collaboration and utilization for youth interacting with our child welfare, behavioral health, and juvenile justice systems. Partners within our communities, court systems, tribal nations, and various county departments were informed and trained on the CANs, and the sharing of CANs within allowable teaming platforms. These are our early efforts and outcomes that we built on to help reduce duplicative efforts and enhance our teaming and sharing of assessments. Next slide. Mindy, I'm going to toss this one to you.
Thank you, Jenny. So next, I would like to just remind us again that AB 2083 accelerated our system of care work, and it allowed to bring all the partners together to the table to reflect and address our gaps within our systems and address the systemic barriers and the traditional provisions of service and focus on the principles of our work and achieve that tangible outcome piece beyond the establishment of our MOU. We asked our teams, what could we do better to get our work done and how can we agree to do this together? This resulted in these guiding principles that you see on this slide that are informing the San Diego system partners, and we're committing to do this work together. We're ensuring that each agency partner is aware and understands the existing screening, assessments, the entry of care procedures of all the other partners that are serving the youth that we combinedly serve. Through this, we're doing this through share and learn presentations, in-service staff and provider trainings, and providing materials to one another. There's also continued joint tribal sharing both on and off the reservations. We ensure to the extent possible that these screenings and assessments and the entry to care systems are collaborating and informing the youth and the guardians through the CFT meetings. We ensure that the necessary and legal timelines for services are being met. We identify the process for sharing assessment information to support coordinated service planning that's consistent with the applicable laws. Again, this is done mostly through CFT meetings, where we're allowed to share case consultations and other multidisciplinary team platforms. These guiding principles led the action items in the discussion and in the process in our development of the AB 2083 System of Care e-learning for providers and staff, and the development of an assessment infographic illustrating assessment timelines for each of our partners and what a pathway may look like for a child entering into care and interacting with our multiple systems. Next slide, please. San Diego system partners identified outcomes and objectives to guide the work, one of several being increased timely coordination and integration of resources between systems to promote placement of youth in permanent family environments, providing care coordination of youth with acute needs, and reduce the time in congregate care. How we plan to get there includes all of our system partners monitoring and coordination the delivery of the child family team meetings monthly with designated coordinators or contractors, to ensure 90% of the CFT meetings are facilitated within designated timelines. System partners monitoring CANS assessments to ensure that 90% of the assessments are completed within 30 days from the entry of care, and that referrals for mental health services and community-based programmings are also completed. In San Diego, integrated service planning and referrals occur within the CFT to reduce that duplicative effort and trauma on having access to multiple systems and being able to have that done in just one place. BHF pathways to well-being liaisons often attend CFT meetings when there's not a provider involved to make those referrals and recommendations. For therapeutic foster care referrals, they're also made when the TFC, sorry, I want to say CFT because I say that one more often, sorry, is recommended. Next slide.
Thank you, Mindy. Thanks so much. So Shelley Paul, I've been the child welfare lead for CANS rollout and implementation in the child and family team meeting, working very collaboratively with Eileen Quinn O'Malley, who's my partner with behavioral health services, and of course, all of our other partnerships. I just want to give a quick shout out to the integrated core practice model. If you guys haven't had time to read it, Google California integrated core practice model. It's 73 pages. It's really big font, pictures, but every single sentence I'm sitting there going, yes, that makes sense. So it's really the guidance for how we should do business as professionals and formal service providers to our families to meet their needs. It's all about transparency. It's all about that family voice and choice and making sure that the family's voice is as loud as the agency voice. I've been with the agency 22 years. 22 years ago, our voice was like really, really, really loud, and the family's voice was like a whisper. We've done much better at making our voices equal, especially in emergency response. Once we make that choice to remove a child, the agency voice gets loud again. So I just want to remind you guys, by coming together in the child and family team meeting and being incredibly transparent, by holding that CANS conversation to create the case plan together in that meeting, we're equalizing our voice. So it's so important. Just wanted to give that quick shout out. Following the integrated core practice model steps, we're using engagement, assessment, and case planning together. We're doing those first three things fluidly in this meeting. When we open a case, whether it's court or voluntary, we have that CANS conversation in the child and family team meeting. We use all of the components that the state lets us. So we use our CANS as our mental health screening. We also use it as our case planning tool, and we use it as our transparent communication about the needs and strengths of the family. We started in October of 2018, holding these conversations. I just started recertifying our team for the third year. It's been an incredible journey. Really excited that I just want to say, when you start, it's hard. It's a big, huge transition. It's a change in the way we've done business, and it's worth it. We've had so many unexpected benefits as a system and a system of care, and as our families. Parents really understand what we're worried about. It makes more sense to them because we're all coming together to discuss it, and then how that links to the case plan items. And because we're creating those action items and the case plan items in the child and family team, the reports I get from social workers are families are getting into services almost immediately. It makes sense to them. By the way, all the things I was worried about, I didn't need to worry about. Things I wasn't worried about, I should have worried about. We're going to talk next month in this meeting more about those things, so I won't go into depth. But we're really working hard to make sure we have the right people at the table. We've amended our CFT referral form on multiple occasions to make sure we're not missing any partners. So when my social worker makes a referral, we've literally listed all the potential partners so they don't forget anybody. That includes our behavioral health services provider, our tribal partners, regional center, our educational liaisons, our pathway to well-being liaison through behavioral health services, court-appointed special advocate, and even the RFA workers listed on there, and so is the ILS worker. So even though those people might not exist for all the cases, it's that reminder, oh yeah, this is a tribal family. Our Indian specialty unit's amazing, they know, but for all of our ER workers, we need to make sure that they're thinking about that when there's any connection. When we get the right people to the table and then the family has their support network, we never want to have like more professionals than the natural supports. That can be a little bit overwhelming. We work really hard to make sure that the family has lots of natural support present so that we get that full assessment and we have a good conversation. It really changes the quality of information we receive. We average 7 to 10 people in our child and family team meeting. And by the way, that includes the kids. The state doesn't have a minimum age for kids. I do call kids under 3 an adorable distraction in a child and family team meeting. However, they can be in there for a few minutes, right? When we have this discussion together with the right people at the table, it really allows us to accurately capture the family's needs and strengths, as well as discuss what services would be best. So we have the providers present, we're working together to create the best services and to share with the family what those options are so they can have control in choosing. We don't write a case plan unless we've had a CANS conversation in a child and family team meeting, and the court holds us accountable to that, which is great. It's really helped with the implementation. We use this as our mental health screening. I mentioned that. So if a child scores a 1, 2, or 3 on those first 9 items, which is either the mental and emotional needs domain or the challenges, then we're making a referral to behavioral health services provider immediately, and we're including the CANs in that referral so it can inform their assessment. After they complete their CANs, they send it back to us. If there's changes, for example, if we put a 1 for depression because there were some symptoms and the mental health provider says, oh, this is actually a 2, then the social worker gets it back and they notify all the members of the child and family team. We refer the child for therapy. The therapist upgraded that depression to a 2, and they will continue the service. So just continuing that transparent communication, making sure we don't have any information the family doesn't have, right? Would you move to the next slide, please? So sharing the CANs, 1 CANs, behavioral health and child welfare do have a slightly different CANs, and we do import it to different systems, but we do our best, as I just mentioned, to make sure that we fluidly share that and that we're using it to inform each other's CANs. Our behavioral health services providers are wonderful. We've created a very streamlined funding stream to make sure when they attend CFT meetings, they are immediately compensated for that. And our social workers don't have to do extra paperwork because we know that can cause delays, right? We've worked really hard to make sure that we're front loading people with information about the CANs and that we're addressing cultural needs of families. So we've done joint trainings, over 30 presentations to the judicial partners, parents, attorneys, minors attorneys, San Diego County Office of Ed, our tribal partners, San Diego Regional Center and Probation. It's not perfect. We've been doing it for a long time. We've done over 10,000 CANs conversations in the child and family team meeting at this point, and we're still learning and growing. As our partners share barriers with us, our families, we come back together to fix those. We upgrade the policy. Our tribal partners shared with us that they weren't getting invited to every meeting when it was an ER worker in the front end and not our Indian specialty unit. So that's why we upgraded the form. We also had a team of social workers who went through a cultural responsiveness academy specific to Native Americans, and they provided me feedback on the child and family team policy. They asked us to include that we have access to traditions, rituals, prayers available for every single family. So now our facilitators literally ask, is there any tradition or ritual or prayer you would like to do at the beginning and end of the meeting? So just really trying to let them bring their authentic self forward and make that part of our process. Next slide, please. And then lastly, we're going to talk a lot about this next month, but the CANs, really, when you use the CANs in a transparent way with a family and create the case plan, you're getting better outcomes. So our social workers are reporting parents are getting into services almost immediately. We've been trying to move the dial on this the whole 22 years I've been with the agency, and we didn't think it was going to be an outcome. So it's been an amazing, exciting outcome. Social workers tell me they get to start unsupervised visitation month 4, month 5 of the case plan. That means we're moving towards unification in 12 months. Really exciting things. And then when we have our correct partners together, we're making sure that they get those services as quickly as possible. It can actually expedite the service process and the approval process when we're together in that meeting. They're already familiar with the family. They know some of the history. We're trying to reduce that trauma for children and families, not having to tell their story again and again, as we've mentioned. And I think that's all I had. Next slide, please. And I'm going to turn it back to Jenny. Jenny, you might be on mute.
Thank you, Shelley. So as a huge takeaway from what Shelley just shared, as far as our collaborative practices around CANs and completing the CANs within child and family team meetings, I hope we illustrated how CANs is seen here in San Diego really as that communal entry to care, and it's completed in a way that invites other systems to come together and collaborate and really have those thoughtful, intended conversations on how to bring services to a child and not have them go through other doors, And that would be more than in support of the no wrong door policy. Thank you, Shelley, on giving that brief overview of how we practice that here in our county. So jumping right into the other opportunities to share assessment, there is a big focus on primarily a lot of what we do shared within child and family team meetings. As you heard, we do have a joint child and family team facilitation meeting contract, so that really supports that effort. Other opportunities available to us here in San Diego to share these assessments include utilizing other teaming platforms that allow by law the sharing of information. We highly utilize our interagency placement committee meetings, barrier buster meetings, other multidisciplinary meetings, and other system partner specific meetings, such as with education, the IEP, the individual education plan meetings, student support team meetings, meetings around 504 plans, and with regional center, meetings around the individualized program plan and individual family service plan. And most recently, and really as a highlight, we have been mobilizing our interagency leadership team to have meetings specific to case discussions, especially when there's high acuity, that's complex, multiple systems interacting. And we've started off to a great start there. We have all our system leaders coming together, so that's another great platform for us to have this sharing of assessments. Next slide. We would now like to share a few case practice successes demonstrating high-level teaming and collaborations that have worked well for us here in San Diego. I'm going to go ahead and pass this one off, and this is going to Kate and Carol for sharing.
Good morning, everyone. This is Carol Vaughn. I'm a program manager with the San Diego Regional Center, and I wanted to briefly talk about a case that we had where there was a lot of teaming with child welfare services. This was a child who was a regional center client based on diagnosis of autism, cerebral palsy, and intellectual disability. She had very complicated needs, not only medical needs, but behavioral needs as well. Due to the family's inability to provide a thriving, healthy environment, she did come into care through child welfare services. While she was taken into care with child welfare services, we immediately started planning team meetings as to best serve this child, who could address her medical needs, who could address the behavioral needs. How do we enrich this child's life? So through multiple teaming meetings, we were able to reach out to one of our foster family agencies who developed a very specialized home for her. The home could address both her medical needs. It was an LVN because she was G-tube fed. And there were extra supports put into the home to address also her behavioral needs. On top of everything, she was also non-ambulatory at the time she went into this foster care home. It was very enriching to see that she did begin to thrive into the home, started being able to take small steps. Her medical needs were being met. She was meeting goals, and ultimately she did become, the foster family did adopt her. So she now lives and thrives in a place, in a home. And I think because of all the teaming that took place and the collaboration of agencies, we also had to involve the SELPA, because she moved out of the one school district and moved into another school district. And I think the teaming and the collaboration really spoke to the success story for this child. Kate?
Yeah, just to add to, just the process that it took to arrive to, what we want is a successful placement in a permanent home for children, because we don't want to re-traumatize children when they're matched with someone that don't have the capacity to support them. So really, this didn't take overnight to happen. I mean, the child was in an emergency placement for, I believe, months. And as much as we, want to move someone into a stable living environment, we want to make sure that we are looking at all the assessments from our community partners to give us, for us to look at what the needs are through different lenses, and to understand what will work. Also engaging providers that both touch our system is important for us, because there's a familiarity between the two systems in utilizing the same providers. So we did approach a foster family agency that both contracts with the county and regional center, and then we braided funding. Once the family is identified, they worked on developing the capacity of the family to support this child, and then off to the side, while the teams are meeting to talk about what is needed to support this family in supporting this youth. Administration is talking about how can we blend our resources so that financials are not a barrier to this child going into the home. So we did do braided funding for this placement, and so lots of, it's not a perfect system, and certainly as Carol mentioned, lots of teaming are happening, discussions around how do we move forward, what do we need, what both systems, what does all the systems involved can bring to the table in order for us to kind of piece together an innovative, unique process, because we no longer have traditional cases anymore. Most of the cases that involve or touches multi-systems are youths with complex needs and families that need support, not just for the youth, but for the whole system. So for us, it's important to partner with all the agencies that we work with to ensure that we're addressing the whole family and not just the youth for a more successful outcome.
Thank you, Carol and Kate. So as you can see from the sharing, there were many pieces within that memorandum of understanding that we're all working on, in which you can see all our roles and responsibilities playing out, from the financial resource management section, child and family teaming, from the sharing of assessments, to even that recruitment piece, recruiting a home that is aligned and will meet the needs of this youth. Thank you so much. I appreciate, and so does the entire team, working with you all and sharing the collaboration. I'm going to ask if we can advance, please. And I'm going to pass the next slide on to Mindy and Jamie with the San Diego County Office of Education.
Thank you, Jenny. I'd like to share a case that's been recent with the local and state calls that have been happening around our students, who have acute needs. We have one individual, a student who came to our attention, and we were asked to participate in several calls now, both locally and statewide. This student has a lot of specific needs for supports and services. And most homes for resource families, STRTPs, are not able to accommodate. I mean, they've looked at several different options, STRP for one, placement in the home with additional supports, even 24-hour care. Regional center homes have been looked at, and we've looked across the state, not just here in San Diego, but really nothing was coming that would really meet the needs of this student. And one of the other things that was unique in this was that when the student came into involvement with child welfare services, the student had been homeschooled for the past 2 years. And so when we started engaging with our residents, the School of Residence for the student, we were able to find out that the local School of Residence had been aware of this student before he became homeschooled and had actually wanted to start the IEP assessment process at that time. And we're more than willing and happy to start working with this student again now. And we're able to complete that assessment process and really have been able to move toward recommending an educational residential placement option as a potential resource as well, which again is highly unlikely in most situations where a student's not going to have any sort of IEP assessment and move straight to an educational residential placement. But his needs are so acute that the school, and being that the school district was aware of him before, they were able to get to where he does qualify for that level of services. What worked really well in this particular case was that sharing of assessments, all the things we've been talking about today, where we're sharing across agencies, the information, the assessments that have been done, the assessments that are needed. You know, these phone calls that have been happening statewide and locally has been able to let everybody think outside the box a little bit differently and really think through what are options, what are things that we could be doing. One of the barriers that did happen initially in this case was that we were having the student was voluntary at first and then became a dependent. And so the district was having some difficulty in deciphering that it was okay to talk to social worker versus parent. And one of the things that really helped in that was our educational liaisons. So we have our regional educational liaisons, and this particular liaison was instrumental in helping to overcome that barrier and being able to communicate the information back and forth around when IEP meetings were happening, things of that nature when there was some confusion, and also again, you know, sharing the proper documentation to show that the student was a student in foster care now for the district to be able to share with child welfare. And also, one of the things that's really great in our county is that blended resource and funding of our educational liaisons. That's a partnership with our child welfare agency. They are co-funded and co-located with child welfare. And that's one of the great things that help to bridge that gap and barrier that we face sometimes between the different agencies when we're trying to support a student like this. One of the things that I'm going to be working on in the next few months with our local LEAs is really informing them about our AB 2083 MOU, what these practices are, and really explaining to them that these statewide calls are happening and how important it could be to be engaging at that local district level and having them being part of those calls, both locally and statewide, because sometimes the piece of the County Office of Education being there, I can't speak to the specifics of that district because again, San Diego County is the size of Connecticut. So the different services between those 42 districts varies tremendously. So, you know, calling on our SELPAs, and Jamie, if you have anything to add, please feel free, but really, you know, trying to vet what is possible from our districts, because sometimes I think there's a misconception, you know, with one of our larger districts like a San Diego Unified School District versus a Julian who's out in our mountain, you know, eastern areas, their services vary so tremendous. And so we really need to have that understanding of what's possible and what districts are capable to help provide in those situations. So that's some work that I will be doing to help kind of move that forward. So thank you.
Thank you, Mindy. I think what's important to highlight in the past two slides so far, in the past two sharings, is really a lot of that liaisoning piece that happens between child welfare services and other system partners. Mindy just shared about the education liaison, and they are embedded in our child welfare regions. And with Regional Center, within our policy and program support, we have a policy analyst who's that liaison as well, to really have those conversations and discussions about what can we do, you know, moving away from what can we not do, but really what we can do. So that's an important piece to highlight in a lot of collaborations. And actually a perfect segue We can next slide, please advance into our partnership and collaboration with our tribal partners. And I'm going to hand this over to Mike Green as well as Karen Cole.
All right, thanks, Jenny. First, let me kind of explain what we have. We in San Diego County since the 1990s have had what's called the Indian Specialty Unit. And that is a dedicated unit of social workers who strictly work with our tribal partners. This helps, it helps that we're following the law of ICWA because that's their specialty. They do that. It really works with our partnership, getting to know our tribal partners and, really hopefully developing trust, which then goes a long way towards our investigations. Karen, did you want to start off and talk about the family we're going to present?
Sure. Can you hear me okay?
Yeah.
Okay. So the photo that you're seeing on the slide, if you can, it's a really good representation of our collaborative efforts. Here in San Diego, we have a protocol and Working for Tribes, one of the only counties that has that. In fact, Mike and I presented to Los Angeles County in hopes that they would duplicate that kind of relationship in their county. But the photo that you're seeing, you can see that this is on the Indian reservation. And if you can see the PowerPoint, the dream catcher is very fitting. That is a risk assessment tool. It was the 3 houses of safety, and through our collaborative efforts, they changed that into a dream catcher where the children and the families have, it resonates better with them than the 3 houses. There's an eagle, there's a dream catcher. And so that's another good example of our collaborative efforts, and also the protocol. So that was a meet and greet. There was 45 people from the county. Those are all child welfare workers from the adoption unit, the hotline unit, the Indian specialty unit, all meeting my staff in all of our services. We are a full service Indian Health Services clinic, medical, dental, behavioral health, and social services, and more programs. So we're able to really work with the families that are in the child welfare eye. The other thing I should mention is that we are also an assessment center. So if children do have to be removed, they come right to their medical home, their Indian clinic, where they know familiar faces, and we're able to reduce trauma to those children. So, and also the hotline are trained to ask at the hotline level, is this an Indian child? But we've been doing prevention services for the past 25 years along with the Indian Specialty Unit. In fact, we have a shared contract with Child Welfare Services that hires my prevention caseworker who goes out on joint investigations and keeping the children on the tribal lands. So in doing that, we drastically reduced the number of child removals, the number of children in foster care, and we were able to reduce the trauma to the families. So I was also asked to present one of the case samples. And this case came into the hotline call, and it was a very familiar tribal name, well known to the Indian Specialty Unit. But any trained social worker looking at risk assessments and everything, knowing what this family, the hotline report with domestic violence, substance abuse, mental health issues, children, young children, 5 years old, would really tip the scales to say removal. But in that tandem investigation, we were able to meet the family with the child welfare worker, look at the services and the support around the family. There was no removal. Instead, there was a referral to our office with that joint position, community services to families referral. And we were able to work with the family, utilizing our tribal resources as well as the San Diego County Resources, Office of Education, Behavioral Health, our mental health, our substance abuse. And today the family is doing very well with the wraparound services. We continue to work with them after 6 months. After we close the case, we continue to work another additional 3 months. and the family's been extremely successful, and there was no need to remove the children and provide any trauma, move them into foster care. They were able to stay home. We worked with the family, and we made resources and had the family utilize their family and doing all the RAP referrals. So they were very successful today. So with that trust and that collaborative relationship, I don't think that would have happened. That would probably have been a removal. But again, we've been working alongside with child welfare for the past 25 years. And this is a great segue back to Mike Green, who I've worked closely with for the past 20 years when we were both on the front line as social workers, and knew each other as we moved up in our respective agencies to managers and directors. So Mike, you want to talk about the collaborative work?
Yeah, I think that, the collaborative work, as Karen mentioned, it really starts at our hotline. When the hotline takes a referral, they're screening to see if that youth, has any tribal relationships. And if they do, they put right in our hotline document, here is the person, here is the contact person, who to call. We contact, we have Indian Health Center and Southern Indian Health Center. And, we work collaboratively with both of them. We for an investigation, we're always calling them. We're going out on the tribal land. I said we do our investigations together. We have monthly CPT meetings with both Indian Health and Southern Indian Health, where all active referrals and all active cases are discussed thoroughly. How, if it's a case, how are we doing? How are we moving forward? If it's a referral, really kind of discussing what services we can try to put in place for that family. If unfortunately it gets to the point where the youth need to be removed, then we're talking about the tribes, okay, about placement and keeping those youth, with family, within their culture, on their land, really moving forward and just, for the best interest of that family. I think the one thing I'm also really, really proud of is, we get invited to tribal events. So not even just necessarily, just on a work thing, but for over Christmas, unfortunately because of COVID, it didn't happen, but we were invited by the Indian Health Council to take part in like a gift giving thing for their families. I think that really shows the relationship and the collaboration we have that we're doing that. I think it leads to mutual respect. If one of my supervisors is calling me for a consult, one of my first questions is where is the tribe on this? Are we seeing eye to eye? I think that also speaks, if we're not speaking eye to eye, is with the relationships, there's a mutual respect. And we don't always have to agree on everything, but I think we can see it through a respectful eye and then, really work together to come to that best conclusion, to keep the kids safe and if at all possible, keep the family together. I think that's it for me. Karen, was there anything else I missed?
Not that you missed it. I think it's also good to share that we're all trained as well. We invite the Indian specialty into our tribal trainings, and we are invited to your guys' public child welfare trainings, your social work initial trainings. So our staff are all trained together and have that relationship too. And it's very important for our community to see the faces of child welfare and really see them as helpers and not people who just come out onto the reservation and remove Indian children from their families. So it's changed a lot. I think with the prevention services in the front line for the past 25 years has really helped that in so much that the community now knocks on our doors or goes straight to the Indian specialty unit when they have relatives that need help. And that's another layer of prevention that we're really proud of. And again, I just want to thank Jenny and CDSS for this opportunity to share.
Yes, thank you.
Thank you, Karen and Mike. I appreciate the sharing, and so does the team and everyone else on the call. So as you can see with those brief illustrations that we had shared, there's really a lot of collaborations going on with multiple system partners, and it was not always smooth. As you can tell back in our very first screen, our Live Well San Diego built that foundation, provided us that platform for this participatory approach and the coming together of organizations and partners. So we basically scaffolded on top of all those opportunities. Hence a lot of our success stories, but not only that, really allowing us to identify those gaps and barriers. If we can advance to the next slide, please, Nancy. So as we start to wrap this up, what's important to share is that the transformation towards an integrated system of care is truly a journey, as you can see from a lot of our illustrations and case sharing. It involves an awareness and understanding of system partners, the respect for our system partners, an awareness of system intersections, transitions, really looking at that ongoing plan for universal screening, enhancing our practice of common assessments, and just moving forward full speed ahead on enhancing our robust CFT meeting facilitation. Continuous quality improvement, that is really important. And the monitoring of outcomes to identify trends, identify gaps and barriers, as well as opportunities for those innovative integrated solutions and reduce redundancy and trauma. Next slide, please. As we wrap this up, our system partner members would like to recognize the executive leadership of the San Diego County Interagency Leadership Team for their commitment in supporting and overseeing the establishment of our shared interagency responsibility, decision-making, in an effort to ensure that services we provide to our collective youth are coordinated, are timely, and trauma-informed. Our ILT has a tremendous task before them, and one of the great significance towards successful outcomes, and one of great significance, I apologize. That task includes supporting efforts towards sharing responsibility, resources, and outcomes, moving systems beyond those prescriptive rules and practices that restrain us in working in silos, and advancing to cross-trainings to figure out the best ways to work with each other, provide for our diverse communities, and to promote practices that leverages existing services, supports, maximizing resources, and blending finances, and promoting cross-system collaboration with leaders and monitoring of outcomes to promote a continuous quality improvement process. Next slide. We hope the information we shared today is helpful and has provided you with additional thoughts for practices for success in strengthening teaming efforts, deepening the practice of shared assessments, enhancing your no wrong door policy or approach, and building an integrated system of care for your collective youth and their families. Thank you for your time and presence, and this concludes our presentation.
Thank you, Jenny, and thank you, San Diego, for sharing your wonderful local practices with everyone today. We have actually reached the end of this webinar and actually run out of time for Q&As, but we do want to invite you to email us your questions that you may have from today, or also email Shelly Paul if you have specific questions for San Diego in regards to their process. I believe Shelly had shared her email address, and that is Shelly.Paul, P-A-U-L-E at sdcounty.ca.gov. Next slide, please. And we also welcome you to submit any requests for technical assistance by utilizing the online form that is shown on this link. Next, please. And invite you to submit any additional questions to the email showing on your screen right now, and that is systemofcare@dss.ca.gov, and we will respond to you as soon as we can. And the following two slides are additional resources that can be very beneficial for you to have. You can find more information on screening, assessment, and entry to care by accessing any of the following links. Next slide. You also have the link directly to the MOU guidance and the link to the gaps analysis and COC document, if you have any time to review that. And a friendly reminder on our next slide is that our next technical assistance webinar will be conducted on February 3rd, and that is part 5 of the MOU, Children and Family Teaming. Please be sure to look out for the registration link. I believe it was sent out with the January TA announcement as well. Next slide. And just as I finish, we would like to take a moment to invite you to present on your SOC local efforts on any of these 4 topics that you see here, either county and local agencies using uniform release of information or data sharing agreement, on your local efforts to coordinate or align services, your local efforts at a fiscal resource management, and cross-training. With that, I'll just say that your modeling of successful practices are very beneficial to other counties and local agencies in the development of their own local practices. So thank you so much for attending today, and thank you, San Diego, for your wonderful presentation.
Great. Thank you, everyone, so much for joining. That concludes the webinar. And if you have any questions, please reach out to the System of Care email. And thank you to San Diego for such a great presentation. Have a great rest of your afternoon. Thanks, everyone.